Welcome to the FMP Essentials Show. I am Dr. Yousef Elyaman, your host, and I am thrilled to have you here with us. Whether you're a seasoned functional medicine practitioner or just starting out on your journey, this show is going to be a go-to resource for mastering functional medicine and making a real impact in your practice and community. Thank you for joining us on the FMP Essentials Show.
Disclaimer: the information presented in this podcast is for educational and entertainment purposes only. It does not constitute medical advice and should not be used to diagnose, treat, cure, or prevent any disease or health condition. Any statements or claims made about specific supplements, nutrients, or other products have not been evaluated by the Food and Drug Administration. Supplements are not intended to diagnose, treat, cure, or prevent any disease. The views and opinions expressed by guests on this podcast are their own and do not necessarily reflect the views of the host or producers. We are not responsible for and do not endorse any statements made by guests. Listening to this podcast does not create a doctor-patient relationship and does not give listeners the right to practice medicine or provide medical advice to others. Only licensed medical professionals can legally practice medicine or provide medical advice. Always consult with a qualified healthcare professional before starting any new diet, exercise program, or supplement regimen, especially if you have a pre-existing medical condition or are taking medications. By listening to this podcast, you agree that you understand and accept this disclaimer. Now get ready to dive in and enjoy the show.
Hello, everybody. Dr. E here. Welcome to the FMP Essentials Show. It is my absolute honor to have my good friend, Dr. Jill Carnahan, here on the show. And what you're about to see, what you are probably feeling already, what I love about Jill is that not only is she a walking encyclopedia of knowledge and experience, but she has a huge heart, which shows even through the computer. I can feel it coming through. So Jill, welcome to the show.
Thank you so much. I'm excited to be here.
Dr. Carnahan, can you give us your 76-second bio?
Sure. So I am a functional medicine expert in Boulder, Colorado. I am passionate about empowering patients and teaching the teachers and influencing the influencers to change the way we do medicine.
Well, you have more seconds. Maybe tell a joke like for the rest of the 30 seconds.
Oh gosh. Well, I love my clinical practice. I'm never going to change that, but I really feel like the way we change medicine is doing like what you and I are doing, is getting out there, sharing the information, really changing the way we think about medicine. And I'm so passionate, which is why I'm so glad to be here, to especially reach practitioners, because that's where we actually shift. Each practitioner can see thousands of patients. So I get really excited when I'm teaching. I know you do too, because we can really shift the way that we think about medicine and the way we problem solve. And at the root, if you're a practitioner, one thing I love to empower you with is we're all problem solvers, and all it takes is curiosity. Curiosity is the mark of genius. So I love to encourage empowering physicians and creating curiosity around, why have we always done it this way? What if there's another way to do it? What else is possible? Those questions will allow your subconscious to solve and create whole new paradigms that will really shift how we do medicine.
Beautifully said. I was hoping you'd tell me a joke, but maybe we'll get a joke at the end.
There's great jokes. I don't have any.
All right, we'll have another. We'll bring you back on just for like a kind of a comedy.
Done.
So at FMP Essentials is for the practitioner of functional medicine, whether it is a physician, whether it's a nurse practitioner, a PA, a naturopath, a chiropractor, a physical therapist, a health coach, because we believe that that we have a responsibility to bring this root cause medicine to the world. And not only that, but we need everybody. We need all the different parts. And as long as we stay within our lanes, if we're all kind of unified in that same mission, then we can make a huge impact, not only in our patients' lives, but in the world. And with that being said, we use the tree analogy here. And the tree analogy is you look at the functional medicine practitioner as a tree. And one of the first things you can see is the trunk. And to us, our analogy is the trunk is knowledge. And what we're going to be talking about knowledge-wise today is a very common condition that affects 10 to 15% of the population, and that is irritable bowel syndrome. So Dr. Carnahan, why is it that you chose irritable bowel syndrome as the diagnosis for today?
Well, interestingly enough, at the age of 26, right after I had cancer, for breast cancer, very aggressive treatment, and got into remission, I was diagnosed with Crohn's disease. Now, Crohn's disease is inflammatory bowel disease. It is not IBS. But what we find is the gut microbiome and IBD and IBS are highly linked. And in fact, one of the studies I want to talk about today with how we really go to root cause is based on those with IBD that went into remission but still had symptoms, and they were diagnosed with IBS. And what are the root causes underneath that? And I think it's a great paradigm to think about it, because so often when I deal with IBD or IBS, it's all about the microbial environment. It's all about the immune system. And regardless of which diagnosis you're talking about, which they're very different, I'm not saying they're the same thing. As a functional medicine practitioner, as a thought leader in this area, you're really going to root cause, and you can transform either of these categories, but they're linked. So because of you asked the why is because of my history with Crohn's, which is completely cured in remission currently 20 years later. I'm very passionate about this topic because I believe that people with both Crohn's, colitis, or IBS can be completely free of symptoms.
Amazing. And that's too. And hopefully we'll get you on in the future after the joke series in order to go over inflammatory bowel, because you have irritable bowel syndrome, which is different. It doesn't have the high calprotectin that we see in the stool. And if you go and do a colonoscopy and take a look at the colon, you're not going to see the same findings as inflammatory bowel. But then you have inflammatory bowel, and in functional medicine, we know that a lot of times you have the same cause, which will lead one person into irritable bowel and one person in inflammatory bowel. It depends on genes and environment and whatnot. So moving on with irritable bowel syndrome, how do you diagnose irritable bowel syndrome?
Okay, so we go back to Europe with the Rome criteria, and Rome criteria 4 has been the latest, and they keep updating these. And I want to just challenge, because I want to be the thought leader challenging the thinking, is to get out of the, like, if you're a practitioner and you're looking at root cause, we have these silos. We have these autoimmune silos, which is one reason why autoimmunity is in so many different categories and not often thought as a whole. But when you're dealing with functional medicine, whether it's gut microbiome, whether it's autoimmune or IBS, which we're getting to in just a second, I want you to think about root cause functional etiologies, which takes away the silos. And that's why I started this with IBD, IBS are not so different than we think. Yes, they manifest different. Yes, there's very different risk. And yes, there's different criteria. But I want you to start thinking about these as gastrointestinal dysbiosis, dysfunction, immune dysfunction, and not into the silos. So yes, we're going to label, we're going to go conventionally, but I want you to start thinking about these as all a spectrum of gastrointestinal disorders. So I want to be the first one to challenge our siloed thinking. But let's talk
nice. No, beautifully said, because you are just getting them ready. Their brain needs to be ready for that shift, right? Yeah. So like you said, there's something called the Rome 4 criteria. You get abdominal pain once a week. You're going to have change in bowel movements, or you're going to have pain with bowel movements, or change in what your bowel movements look like. And then you have that criteria, as long as you can't find another cause. And what's it?
2 and 1 for Halloween. Yeah, the abdominal pain 1 day per week, at least 3 months on average, are related to either defecation increase or improvement in the worsening or improvement in pain, changes in stool frequency and stool appearance. So this is super broad. And like you mentioned, the red flags are bleeding, iron deficiency anemia, unintentional weight loss, palpable abdominal mass or lymphadenopathy on exam, family history of colon cancer, and they have not had age-appropriate screening, onset of symptoms after the age of 50, or sudden onset. Those are the criteria where you're going to want to do a full workup, a full colonoscopy, and rule out any other causes like Crohn's, colitis, cancer, etc.
No, very, very well said too, because what the last thing we want to do is call somebody irritable bowel syndrome, and they really have pathology happening. Because even if they have inflammatory bowel disease like Crohn's or ulcerative colitis, that is a risk factor for cancer. I really like checking a calprotectin here, because if the calprotectin is less than 100, your chances of having inflammatory bowel are very low. When it's over 100, that even if they have inflammatory or irritable bowel syndrome, if their stool calprotectin is over 100, that's when I'm going to say, all right, go back to GI. Let's go ahead and get a colonoscopy and see what's happening. So, and I'm sure that's a test that you're testing in your practice, and it's part of your stool panels. So we talked about, so with the Rome criteria, basically you're ruling out other causes. One of the things I don't like about irritable bowel syndrome, I do think it's kind of in the naming of it, I think it's kind of like an archaic diagnosis, because it was basically, if you have issues with your gut and we can't figure out why, we're going to call it irritable bowel syndrome. But the reality is, and what I learned in practicing and studying and researching functional medicine, is that if you dig deep enough, a lot of times you are going to find out the cause. So there's no real test that we do for irritable bowel syndrome, but how would you now, as a functional medicine practitioner, how are you going to start working this case up? You mentioned colonoscopy, right? To make sure that they don't have Crohn's, ulcerative colitis or cancer or masses or whatever, right? But how are we going to, in functional medicine, go deeper thinking about root cause medicine? What other tests would you do?
Yeah, and so just to be clear, those things that I named off are the red flags that you would absolutely want to order a colonoscopy. If you have no red flags and you fit the classical IBS Rome criteria, and you have a normal calprotectin, which is what you mentioned, you have a 99% chance that you're not dealing with anything else, and you can safely, as a primary care doctor or gastroenterologist or whoever you are, move forward with more deep root cause functional testing without a colonoscopy. So again, to be clear, if you have normal calprotectin, 0 of those red flags in an otherwise healthy individual, you do not have to order a colonoscopy on every patient. And that frees us up because you have a 99% likelihood, according to the research, you're not missing something more serious. I think that's maybe one of the most important things we say today. So then what do we do functionally? So functionally, pretty much every patient that comes in, and especially a patient with IBS, which is a lot, I think 33%. You've had another statistic of primary care visits, about 1 in 3 are related to the gut IBS symptoms. So I always do stool testing. And right now we have so many different labs and options out there. I do multiple tests. I don't have one that I like. We have PCR test and we have culture test and we have combinations, and then we have the more metabolomic kind of tests. And I use a multitude. I would say I still use the classical, both PCR combined with culture. I find that to be the most accurate. Um, and sometimes what I'll do is if I get one test and then I check again, I often do another company because I feel like it's like looking at the elephant in the room and talking about the head and the tail and everything there. I see sometimes different reflections of the same microbiome on different testing. In fact, I just talked to my PA this morning about a really tough Crohn's case. And I said, let's do 2 tests, same time, split sample, because often I'll get slightly different information. So don't be afraid to even order more than 1 stool test on your most severe patients. That's number 1. Organic acids is number 2. Everybody gets organic acids. I feel like these actually show some of the things like fungal markers or Clostridium markers that you're not going to see on the stool, because we're looking at, and in a minute, I'll go through differential causes of IBS, but we're wanting to see the colonic microbiome and what's going on there. Is there any change in inhabitants? These guys are like a community. And when you get the thugs overgrowing and there's not enough police officers to keep control of the environment, that tends to be this shift in microbiome that can create inflammation or symptoms. And it may or may not be a pathogen like E. coli or salmonella. It may be a simple thing like Provotella or Citrobacter or Klebsiella that's just a little bit too high. That's colonic, and we usually test that by looking at stool. However, a lot of symptoms come from small bowel dysbiosis. This would be SIBO, small intestinal bacterial overgrowth, or SIFO, small intestinal fungal overgrowth, or IMO, intestinal methanogen overgrowth, which used to be thrown into the bucket of SIBO, but now it's its own category because methanogens are not really bacteria at all, and they tend to create a more constipated environment than the loose stools. So you're going to look at organic acids, you're going to look at stool, always blood work. And in the blood work, I'm doing all the basic CBC, CMP, liver, kidney, thyroid, hormones, autoimmune markers, at least screening with ANA. I'm always doing immunoglobulins. A lot of people don't test those, but I want to make sure we're not dealing with a selective IgA deficiency, because that's very highly associated with celiac disease and highly associated with ongoing dysbiosis and IBS symptoms. So you want to rule that out. I'm also checking an IBD panel. This is going to rule out any Saccharomyces-related antibodies or arabinose antibodies, are basically all related to carbohydrates. And there is a predictive factor with the IBD panel. It's the anti-Saccharomyces antibodies and the other 3 that are there. I wrote about it in an article. And they're highly predictive of the aggressiveness of Crohn's. However, if you're testing in a patient that doesn't have Crohn's, you can still see pieces there that show they have an anti-carbohydrate or an anti-Saccharomyces antibody, which means you're dealing with a fungal issue. So it's one more way to look at fungal issues. And then I'll typically look at a few basic cytokines. I'll rule out mast cell disorders with the whole workup, which includes tryptase and histamine. because often mast cell disorders is another differential for IBS.
So let's take that. Let's kind of unpack that a little bit. So we'll start with stool, and we can't go over all of it. And it's interesting. So conventional medicine usually isn't going to look at a stool test at all. Why is that?
Well, I think that, again, they're looking at what we're best taught in medical school is how to treat with surgery and drugs, and they're perfectly appropriate. But those are a toolbox. Our toolbox is quite small. We're not taught in conventional medicine how to find an abnormal imbalance that's not pathology. So here we are in spectrum, right? Wellness and illness. And often we're working in these gray areas that aren't full blown diagnosis, although it might be IBS. And we're dealing with just imbalances that create dysfunction, that creates symptoms, but they may not fully fall into a category that needs a drug treatment. And so because of that, conventionally, we're not really taught to look at the gray areas. And you and I, all we do is look at the gray areas.
Like looking for patterns, looking deeper, trying to figure out why. Because once again, calling some irritable bowel syndrome could be like hypertension. What does hypertension mean? It means your blood pressure's high, right? It's like saying you have fever. Well, that's great, but what's causing it? So aside, because I want to kind of go down this stool line. So you're taking a look at the stool, and one of the things that you're mentioning is taking a look at potentially dysbiosis, right? Dysbiosis or abnormal bacteria or abnormal flora inside your intestine, inside your gut. So you had mentioned you like
map, if you want, of the stool. It's pretty. So DIGIN is an acronym we've used for years. I've taught for 20 years in the GI modules, and D is digestion. So first thing you're going to look for is pancreatic enzyme production, which is typically done with pancreatic elastase. Second thing you're going to look for is protein in the stool if they're hypochlorhydric or low stomach acid. And then the third thing might be fats in the stool, which is another sign of maldigestion, malabsorption. That's your D. The I is inflammation, immunology. This is where you're going to look at.
So hold on, Dr. Carnahan. So, all right, let's start from the beginning. So you mentioned you're going for the dig. So you mentioned acid, low stomach acid. What else did you mention? What was the first one?
Pancreatic elastase.
Pancreatic elastase. And that's a stool test. You can check that at a conventional lab. You can check stool for pancreatic elastase. How are you checking for hydrogen, for low hydrogen in the stomach?
So there, you can either check with protein in the stool, or there are some markers on the organic acids. I know the number.
Well, let's talk about the stool. Let's go back to the stool. So if you're seeing the undigested proteins in your stool, then there's a chance that you have low stomach acid, but it's not 100%. Right?
Correct. You could be either eating too much protein. Say you're a athletic male who's eating 200 grams of protein a day. You could
wait. Why'd you look at me when you said that?
It's very high protein. High. So you could be spilling protein if you're eating too much. You're not properly absorbing it. So it's not always a case of maldigestion. But
Right.
if you're eating a normal amount of protein and you're actually spilling protein in the stool, you're probably not breaking that down. And that typically goes back to the stomach acid as a first line of breakdown of protein. You might also see, to corroborate this information in the blood work, low ferritin, low calcium, low protein, low albumin. You can see other markers of maldigestion of proteins with minerals.
In the blood. Okay.
Yeah, and even B12, because you need stomach acid and intrinsic factor to absorb B12. So if you're seeing low ferritin, low iron, low protein, low albumin, low B12, there's some maldigestion going on, and that would be stomach acid.
And
then
that you're talking about in serum, but back to the stool.
Correct.
Seeing that protein could be a sign or a clue, but you could still have low acid and still have the protein looking okay in the stool. And then you also the other thing when it comes to stomach acid, I think just so the audience can kind of appreciate, acid is supposed to pour into the small intestine, killing off a lot of bacteria. And if you don't have that happening, then you can start to get overgrowth, which actually brings us, well, I want to kind of continue with down the line of what you're looking at in the stool, but then hopefully we can talk about the place where the bacteria is at kind of makes a difference as well. So back to the stool. So you're going to look for different bacteria that may be causing a problem that are dysbiotic. You're looking for signs in the stool that they don't have enough stomach acid. What else are you, just the overgeneral, what are you looking at in the stool when you look at somebody's poop?
Yeah.
You're looking at?
So, and I want to go back to that because that's really, really important. So you have stomach acid, the first line, breaking down food in the stomach. As soon as it goes in the duodenum, it becomes alkaline as you increase pancreatic enzyme secretion from the common bile duct. And so then it changes from acidic to alkaline. Both are crucial for preventing SIBO and SIFO. So what you said is critical because say we're down the road here and we're seeing evidence of SIBO or SIFO, bacterial or fungal overgrowth. You must, as a good clinician, go upstream and say, why did this happen? Because if you just treat that with antifungals or antimicrobials, it will come back again and again and again. And if you're not looking upstream, which is why we're talking about this topic, stomach acid low, low pancreatic enzymes, poor motility, poor digestion is all going to affect. And all of those things can actually affect the microvilli, which is where the nutrient absorption occurs. And if those are denuded or ruined or partially there, you're going to have malabsorption of all kinds of nutrients. So it's all this really important thing. So in the stool, we said pancreatic elastase, we said protein, we said fecal fats, which is again another sign of fat malabsorption. Then we go down to the inflammatory markers. And this would be calprotectin, lactoferrin, eosinophilic protein X. They all have slightly different personalities. The calprotectin is more neutrophil driven thing, so it's more bacterially related, and it's also highly associated with Crohn's and colitis. I actually will monitor Crohn's and colitis activity while I'm treating with the calprotectin because as soon as it goes below 200, you're ideal. Even below 100 is even better. That's totally normal. Lactoferrin is very similar. It usually reacts to the neutrophils. It's a much more bacterial marker. It's a little bit less specific than calprotectin. So I typically, if I have to choose, I'll choose calprotectin. It's more specific. And then we have eosinophilic protein X. And as it sounds like, it relates more to eosinophils. So while it can also be high in inflammatory bowel disease, more likely it's related to parasitic infections, food allergies, chronic alcoholism, pancreatitis, and a few other things that are not so much the Crohn's and colitis bucket. So that's your inflammation. And you'll typically see in that bucket as well SIGA, that's secretory IgA. You can have a very elevated IgA level if there's something irritating the mucosal lining. So when I see high SIGA, I say, what is bothering that mucosal lining? It could be bacterial overgrowth, could be an acute infection like Salmonella Shigella. It could be a parasite, and it could be something like gluten that's irritating that mucosal lining. So you look at food allergies, you look at parasites, you look at infections. And if it's low, we know that
intolerance. IgE is more of intolerance, right? Versus IgE mediated allergy. You're talking about stool IgA, right?
correct.
Yeah. And IgA is an immunoglobulin. You want to tell the audience, for our health coach, functional medicine practitioners, what IgA actually is?
Yes, you have immunoglobulins, which are your antibodies, the little Y-shaped things that grab onto a particulate and bind and neutralize a virus or bacteria. And we have IgG, which is systemic. We have IgM, which is acute systemic. We have IgA, which is mucosal surfaces, sinuses, gut, lungs. And then we have IgE, which is immune systemic, more of an allergic. And like you're saying, the IgG would be your classical allergen, like peanuts or whatever kind of things. The IgG, IgM, IgA are more mucosal or systemic intolerances that have developed due to a permeable gut. So they're very different from a classical allergy, but they can cause some significant symptoms. They're usually more delayed than acute, and they just have a different pathway.
Right. So, and you're saying their IgA. So if their IgA is high in the stool, what does that mean?
So high is going to be something, think about angry bear, you're poking the bear. Something is irritating that mucosal lining, and you have to be a good detective and say, is it an infection? Is it a toxin? Is it mold? Is it a food? And it could be any number of those things. And you find out which that is and take away that. With IgA, you don't like, what's the supplement? No, you take away the bad. That's how you get to that root, because if you add something to that, that's not going to fix the problem. And just on that note, just a little thought here, super important. You can never, never, never heal a leaky gut until you take away what's irritating that leaky gut. So say someone's in a moldy house and you're like, oh, I'm going to give him glutamine. I'm going to give him this. And someone said, this is great. No, 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 no. No amount of glutamine will repair leaky gut if they're still in mold or if they still have an infection. You must go to the root cause, and none of that will work until you do.
And IgA, and you said leaky gut. So for those that are like, oh no, she said leaky gut, she must be a hippie. What we're actually talking about is increased intestinal permeability, which is very well studied and described in the literature. So before you freak out with leaky gut, the gut is actually leaking. It's called increased intestinal permeability, and that's where usually the gut is supposed to stop large particles from getting in our system. But now what ends up happening is because of inflammation, these large particles that should have no business being in our bloodstream leak in our bloodstream, which can cause autoimmunity and all kinds of other issues. So what if the IgA in the stool is low? What does that tell you?
Low. First thing you think about is stress, because our catecholamines will reduce IgA, so will low adrenal function. So you want to look at stress, and then you want to look at any other thing impairing the immune system. And with that, I would be sure that I'm also checking serum IgG, IgM, IgA, IgE, because many people we see have undiagnosed immunodeficiency syndromes, and you'd want to make sure. And stool IgA and serum are very different. Stool is much more fluctuating with the microenvironment of the gut, whereas serum, you can actually diagnose selective IgA deficiency if it's low on the serum.
So another thing in the stool are the small chain fatty acids, right?
Yeah. Mhm.
So can you tell us a little about that?
Yes, those are like the new heroes, because increasing short chain fatty acids, even eating bitter foods, will increase GLP-1, which is the big popular thing right now. But we can do that naturally by increasing our short chain fatty acids. So if you actually increase butyrate, and you can do that through fiber-rich foods that are fermented in the colon. That's how we make short chain fatty acids. But you have to have a healthy, diverse microbiome in order to do that. And in our stool testing, you can actually measure the levels of butyric acid, propionate, and all the different short chain fatty acids to know if they're adequate or not.
Okay. So, and if you see the short chain fatty acids being off, being low, what do you do?
So you need fiber that's fermentable in the colon. But once again, there's an order of operations, because if you just throw fiber at a patient who has IBS and who has SIBO, SIFO, they're going to feel way worse because they're feeding the wrong thing. So you really have to take care of that dysbiosis before you add in loads and loads of fiber. But the fiber is and I always say, whether it's probiotics or any of these things that people are wanting to use, food is the main source of the short chain fatty acids. Food is the main source of a healthy, diverse microbiome. No amount of probiotics will overcome an unhealthy diet.
Now, so fiber, but you have to be careful with it. Are there any, and food is best, are there any particular types of fiber that you would recommend they buy? Should they just go to the store and buy psyllium?
Yeah, so there's inulin, fructooligosaccharides, galactosaccharides, and then there's some of these new selective fibers that a lot of the companies are using that are supposed to be less likely to induce SIBO or gas or bloating. I always have patients get, chia seed, flax seed, psyllium husk, hemp seeds, and put them in their food, in their cereals, in there, because those are just great fibers. And then just great leafy greens and artichoke. A Jerusalem artichoke is a great fiber. So a lot of these things that already have inulin as food is the best, but you can add some of these things to your smoothies and things to add fiber. And really, you need all types.
And so if then we could kind of segment into this, because I think we've really kind of hung out in the stool for a while. So, so maybe, and that's because of me, because I kind of pushed it, but about 60 to 80% of people that have irritable bowel syndrome actually have something called SIBO, which what we could talk about next, small intestinal bacterial overgrowth, where the small intestine that's supposed to not really have that much bacteria or fungi get overgrown with what might actually be good if it was a little bit lower down in the tract, and it
Yeah.
can cause a lot of those symptoms. But that being said, there was a study that showed that if you gave people rifaximin, the antibiotic to kill off that bacteria, plus you gave them partially hydrolyzed guar gum, that changed the eradication rate from about a 60% to an 80%. So I like giving people as a fiber, I like giving them the partially hydrolyzed, but they have to be careful. If they just get guar gum that's not partially hydrolyzed, it'll mess up their stomach. Like they'll feel it. So can you tell me about SIBO?
You got it. And I wonder if, just to frame it, we should just really quick lay the landscape of what are the underlying things of IBS. And then I want to talk about SIBO, but I would love to lay the landscape.
Oh,
And
let's go back to that. Okay.
And just for your listeners, there's a great article, one of my favorite recent ones, out of Digestive Diseases and Sciences. It was September 2023, called Irritable Bowel Syndrome, Like Symptoms in Quiescent Inflammatory Bowel Disease, A Practical Approach to Diagnose and Treat. So once again, this was an article related to, if someone, and again, we're not talking IBD, we're talking IBS, but it's so relevant because it's like, if someone is treated for IBD and still has symptoms, maybe they have IBS, which is our topic, and these are the underlying causes. And it's one of the best overarching things. I was researching mast cell, and mast cell is in the differential, and a lot of docs aren't thinking about that. So I'm going to just briefly run through that, and then we'll dive into SIBO.
Okay, so going from we'll move from the stool approach, right? So then the next thing that we can look at is serum. And you kind of mentioned a little bit, but you're going to look at blood. There's some common labs that you're going to look at blood. Is there anything else you want to talk about with the blood before we go to another?
Oh, got it. No, I think I named everything that I would test.
Okay. And then you talked about doing, and you know what? We'll save this for the more, for kind of the private group where we'll talk more about the fungal, like the
Sure.
fungal overgrowth and that type of thing. What else would you like to talk about before we talk about breath tests and whatnot?
So we can talk about testing if you want. Otherwise, I can talk about differential for IBS.
Yeah, let's talk about the differential.
Okay, you got it. So SIBO, obviously, number one thing, it's most common. I mentioned intestinal methanogen overgrowth. And again, what we'll do next is talk about the breath test because you can differentiate those two, intestinal fungal overgrowth. So those are all the small bowel things that can go wrong that can lead to IBS type symptoms.
And
Now,
that's starting high. So we already talked about how not enough stomach acid going down the track, not enough stomach acid can cause issues, right? Which can lead to IBS symptoms. Then you go further down, you have that small intestinal overgrowth. The small intestine can be filled with bacteria and fungi, which can then be one of the causes, which is what you're at. And you're talking about doing the breath test. How do you do this breath test?
Sure. So breath test is going to be usually lactulose or glucose, depending on your country and your lab testing company. They can both be done. They're both accurate. And what you're going to do is every 20 minutes collect a breath sample. These can be kits. They don't have to be done in the office. And there is a very specialized diet that you can find, depending on your test company, that needs to be followed in order to have an accurate test. And then you're going to test the breath every 20 minutes for methane and for hydrogen. And the newer kits will actually test for hydrogen sulfide, which up until recently has been undiagnosed and one of the most difficult to treat SIBO. So if you could get years ago, if you just got the hydrogen and methane and you're like, boy, they still seem like they have IBS, you might have been missing that hydrogen sulfide component, which is a big deal. And that's how you do it. You're going to see over 3-hour time. 3 hours is the best time frame. If you're looking at hydrogen, it should start low. And then if it goes up over the time frame, it should be above 15 if it's positive. If you're looking at methane above 5, although there's some criteria that say as low as 3 and as high as 10, there's a range. Pimentel's group, I think, uses 5. And then the hydrogen sulfide, there's a lot of controversial there too. I think it's above 3. And a combined methane and hydrogen above 20 is going to be positive. So those are your criteria for a positive test. If it's positive, you go ahead and treat.
Okay. And let's talk about it. How do you treat it?
So with hydrogen, just plain old hydrogen, you can use something like rifaximin, which has been an interesting, again, Pimentel's group has just been coming out with saying you don't even have to do the breath test in order to treat an IBS patient because there's such a high incidence of improvement. So I've actually been leaning more towards his very new recommendations that either are just published or just about to be published relating to using rifaximin for IBS criteria without doing a breath test. And I think that's probably appropriate. Time will tell. So that's rifaximin for hydrogen positive. Now you can also use, there's several herbal regimens that have been studied that combine berberine and oregano and different herbs. And really, I probably have 20 regimens I've used successfully. So you need to, as a functional medicine doctor, get used to some of the stuff that's out there and find what works. Usually berberine, oregano, garlic, caprylic acid, undulaceic acid, uva ursi. Those are just some of the things you can use.
So the interesting thing with the garlic, and I'm sure we'll get into it, but one of the food plans that you have people go on when they have SIBO is what's called a low FODMAP food plan. And garlic can actually trigger SIBO, but allium inside garlic can actually kill the bacteria. So you can get a kind of an allium extract. And for those people that have irritable bowel syndrome and are trying a low FODMAP food plan or low FODMAP diet, one of the tricks they can do is they can saute the garlic or the onions, and then they can strain it. And that takes the fiber out of it so that it doesn't affect their stomach and they can still have that benefit. But just a little side ADHD note. I like that you said there's over 20 different combinations. Because what ends up happening to us functional medicine practitioners is that they go to the GI doctor. The GI doctor says you have IBS, see you later, and really give them not really much to do. And then the patient's taking a look at us in primary care in general, whether you're functional or not. And then now we have to do something. So you have to get good at figuring things out. And obviously you figured out different combinations of herbs and different supplements that have helped patients. And it's kind of like a trial and error sometimes, because you can treat I think you alluded to this before and mentioned this in other areas, but you treat it. And after you treat, you give them rifaximin, right? And then their symptoms go away. If you don't fix the reason they had SIBO in the first place or irritable bowel in the first place, guess what? It's going to come right back again.
Exactly. That's exactly what happens. And that's why. So if you're just dealing with hydrogen, it's pretty easy. There's pretty easy herbs. There's pretty easy treatments. It's usually a 2-week course for the medication and up to 8-week course for the herbs. That's a hydrogen. Methane is harder to treat. This is a methanogen that is resistant. So typically we use a combination of either neomycin plus rifaximin or metronidazole plus rifaximin. I like to use tinidazole because I feel like there's less side effects than metronidazole. Either way works. The combination is also 10 to 14 days. And same thing with the herbs. Although with the herbs, I typically add in alum, the garlic extract, or sometimes I'll use grapefruit seed extract, which tends to be very good, or even uva ursi. Those are some of the weird herbs that tend to work a little better on the methanogens.
You ever use, a couple things that I've been experimenting with are the IgY kind of biotic. Basically it's they take a hyper-immunized egg and they take the antibody out of it, and then they use that antibody with maybe some spore probiotic, or the bovine-derived immunoglobulins, where they spin cow's blood basically and take the plasma and take the antibodies and put that in a supplement. Have you been using that at all, or?
Yes, every one of my gut patients gets a spore probiotic plus bovine immunoglobulins. So those are kind of the core. Those immunoglobulins are going to be passively binding LPS and some of the garbage that's being created by this. So yes, I love those 2 protocols for sure.
Okay, nice. And then, if they have an issue with the beef, well, it comes from an egg.
Yeah.
Right. It comes, and from the egg, no chickens were harmed in this.
Right.
Okay. So you talked about medication, so if it is SIBO that's causing it, medication, herbs. I mentioned the FODMAP food plan, which you just got it. Do you have like a favorite handout you give them for a low FODMAP?
I like Alison C. Becker because she combines FCD and low FODMAP, and I think it's probably more effective than the FODMAP alone, because the FODMAP alone is like eat white bread and white sugar, and I'm not really keen into that.
So 60 to 80% of our patients with irritable bowel syndrome probably have SIBO, and doing what you just talked about will help them significantly, right?
Right.
What about the other 20 to 40%? What else can cause irritable bowel syndrome?
So the first caveat is you have to make sure you're not dealing with co-resistant SIFO, fungal overgrowth, because if you treat with rifaximin and you have SIFO, you're going to make that worse. So frequently, say I do find someone with SIBO, SIFO, or IMO, or all 3, I'm giving them rifaximin, neomycin plus fluconazole. I'm hitting them with 3 drugs of covering all things, or herbs. But again, herbs is a way to do it where you almost always with your herbal regimens are covering both fungal and bacteria. So if someone has SIBO and SIFO, I usually lean towards the herbal regimens versus the drugs, and that would be another way to decide. Now, other things that you may not be thinking about, even if you're conventional, these are all conventionally documented in the literature, malabsorptive syndromes like carbohydrate malabsorption, bile acid malabsorption, exocrine pancreatic function. Those are all just malabsorptive symptoms that can mimic IBS and not necessarily be related to SIBO or SIFO, although, as we talked about in the beginning, if you have pancreatic exocrine insufficiency, hypochlorhydria, or other malabsorptive syndromes, you're going to be more likely to have overgrowth in the small bowel. Immune-mediated symptoms, I started this at the beginning, mast cell activation can mimic IBS. And there's more mast cell activation disorders than ever before for multiple reasons. And you have to be really aware if you're dealing with a mast cell activation syndrome, because the lining of the gut contains a huge amount of mast cells. And if you're not addressing that, you won't get the patient better. And that's an immune-mediated Eosinophilic disorders. This is in the differential. You could have eosinophilic esophagitis, eosinophilic gastritis, or any number of eosinophilic disorders in the entire GI tract that could mimic IBS, and your rifaximin and those things aren't going to help that at all. Non-celiac gluten sensitivity or celiac disease. These are also in the differential. And typically, I didn't mention this, but I always do a celiac panel on the blood for patients, checking deaminated gliadin, IgA, and IgG, and then TTG, IgA, and IgG, so that you're ruling out a celiac and you're ruling out a non-celiac gluten-sensitive patient. There's a little less common disorders like endometriosis with a woman could mimic IBS, and it'd be a totally hormonal outside the bowel issue, but it's obviously affecting the bowel. Intra-abdominal adhesions, if they have had frequent surgeries, you could have adhesions that are affecting motility and causing SIBO or causing issues. In fact, I have probably half a dozen patients that have colectomies from Crohn's. And when you have no colon, you're almost guaranteed to have small intestinal bacterial overgrowth because you don't have the normal junctions to prevent that overgrowth. So those are the kind of patients where I would prophylactically keep them on rifaximin. It's a very special case, but they often need that because they have no colon, they have no.
Do you cycle them? Do you do it like a week out of the month, or do you just have them take it continuously?
I will have them take it continuously if they truly have a colectomy and SIBO is there all the time. I will have them on prophylactically. And it actually is indicated for the liver overload, right? Which is basically non-alcoholic fatty liver disease and all that, which is very connected because you're dumping bacteria into the bloodstream and getting that liver effect. So rifaximin is also indicated for that.
Dr. Carnahan, that was a great overview. And now it is time to spill those functional medicine organic beans. Let's go over the stuff that people can't get based on just going to ChatGPT or AI, the stuff that it's our clinical experience that we really need in order to help patients, those more difficult patients. It's time for our clinical experience share.
To unlock additional premium content, including the deeper dive in this clinical topic, leadership and speaking tips, charting and efficiency pearls, and business mastery as a functional medicine practitioner champion, be sure to check out our mastermind and other membership programs at www.fmpessentials.com. Hey everyone, we hope you're enjoying the FMP Essentials show so far. Pretty amazing, isn't it? Remember, if you're part of our mastermind, don't miss out on our exclusive bonus clinical content. That's where we take a deeper dive, look at personal experiences and real-world insights that you can't just get from a book or from looking on AI. It's where we really get into the nuances that make a difference in your practice, the experience of the guest of our show. Thank you for watching, and we hope you enjoy the rest of the show.
Part 6, Making an Impact. All right, Dr. Carnahan, back to the functional medicine practitioner as a tree. You have the tree, you have the leaves, you have the roots, but you have the fruit that the tree produces, but then there's also seeds. And seeds and planting seeds is our legacy. It's mentorship, it's community involvement, it's giving back. And we believe strongly that functional medicine practitioners should lead the way in giving back to community and making the world a better place. So I have a couple of questions. One is, what are some impactful ways that we as practitioners can contribute to our communities?
Yes, I'm passionate about how do we connect emotionally with people who maybe don't know about functional medicine or practitioners who are unaware to really shift. And I know that just like when we talked about the book, you can't do that without story. So I've been really involved in the arts, especially filmmaking and documentaries, because I feel like that's one way to reach the general public that we might be able to do with a lecture. People who are interested, of course, are going to sit through a lecture, but a movie, you might be able to get somebody who has no interest in functional medicine, but they're like, oh my gosh, I can't believe that's possible. So personally, I feel like the arts and some of the ways that we can reach people, and you might not think that's related to medicine, but it is because we're touching people at the heart level and showing them that something else is possible.
Tell us about your book.
The book we talked about, the movie is drpatientmovie.com. This was a project of labor of love. We had a private investor. We'll never ever make that money back. So this is not a money-making project. It was purely for the sake of getting the word of functional medicine out. And we found a whole different stream. And in the realm of like film festivals and that, there's a lot of people out there doing environmental message, amazing consciousness there. But it's just starting to shift to where things related like pain brain and so there's a Dr. Bredesen movie, a documentary, and some of these things related to functional medicine principles. I think the next level in getting to the public is film and on because you remember in the pandemic, everybody was, I remember 2021 study, like everybody's on screens. If I want to reach people, is anyone even reading a book anymore? So I kind of shifted my thought to what if we get on screens? And I think that's the next level because people are on their phones, they're on their screens, and whether it's an app or a podcast or a movie, that's, I think, where we're going to make the biggest impact in the largest way.
And you talked about absolutely, and maybe we need like to get into that, the hologram kind of
Yeah,
future,
right.
whatever's happening. So you talked about your book in the kind of practitioner only
yeah.
section, right?
Yeah.
Let's talk about, I want everybody to know the name of your book and what your book is about.
Oh, thank you so much. So it's called Unexpected, right back there, Finding Resilience Through Functional Medicine, Science, and Faith. And I was told by the publisher, you can't write a memoir, no one knows who you are. But I felt so strongly that story is what drives. And so I told my story. It is a memoir, but it also includes patients. And it's kind of like a 2-in-1. So you have the story, the memoir, the heart piece of how to survive almost anything. You could call it that because I've been through Crohn's, colitis, cancer, mold-related illness, etc. But on the other hand, there's a very practical sidebars in every chapter on different practical tips, how to prevent mold growth in your house, how to change your diet to prevent IBS symptoms, what to do if you're struggling in a relationship, and all these practical tips. You could just flip through and go through those sidebars and get some practical information as well.
Awesome. And so you don't always listen to the publisher, huh?
Right. That's
That's the thing. So like in order to be innovative, you can't do what everybody else does. Actually, that reminds me, I know in functional medicine, we are thinking outside the box, right? Because if you look at it, when somebody is, when somebody's family member is sick, they don't say, I want a doctor that's going to do what everybody else does, right?
Right.
But if you look at our medical training, we were told standard of care, you do what everybody else does, right? You got to follow the standard. But I don't say, oh man, my family's sick. I want a doctor that will do what everybody else does. I want to put them on the same protocol that everybody's did and diagnose the same way. We want somebody that is going to think outside the box. But when people don't follow that, when they're looking beyond, sometimes you got people doing some really scary things that they probably shouldn't be doing. And then you can have like people doing great things. And hopefully we're on the side of great things. And in order to, sometimes you can't just go with what everybody else says. You got to follow your heart. And I know your book, I've been seeing it everywhere. It's successful and I wish you much more success. On a larger scale, are there any organizations that you recommend that we maybe donate money to? I know I like donating to IFM and Environmental Work Group. Is there anything that you recommend to make the world a better place, a healthier place?
Yeah, two come to mind because of what I'm supporting. ICI, which is International Society for Environmentally Acquired Illness. It's mold environmentally related docs, nonprofit. And then the new IRIS Global Health Film Festival, which I've been helping to fund because it's bringing documentaries to the world that are health related, functional medicine related. Kind of like I've got into it since I've been involved in the documentary. And I think that's such a place where I can help support and bring more films that relate internationally to functional integrative medicine principles.
And speaking of giving back, you have the most precious thing we have is our time. You go to any older billionaire and they would trade their money for their youth any day, right? So, and you have been so generous with your time and your wisdom and your experience. And I want to thank you for that. How can other functional medicine practitioners, but even those functional medicine champions, how can they stay connected with you?
Oh, thank you. And thanks for the work that you do. I feel such a mutual admiration and love, love, love this new style. I love this podcast is going to change lives. So thank you for doing it. So you can find me at my website, which is just jillcarnahan.com. It has links to the book, to the movie, all my blogs and everything else that I do. That's probably the easiest way to find me. If you want just the book, you can go anywhere books are sold. It's also at readunexpected.com.
Awesome. Dr. Carnahan, thank you again. I know you have to run see a patient, so go see your patient. I will go edit this,
Well,
and I can't wait to see you again.
thank you
Take
so
care.
much. Yeah, have a great day. Bye-bye.
Hey everyone, I'm Dr. Yousef Elyaman. We hope you enjoyed the show. For more exclusive content from this interview, check out our FMP Essentials Mastermind. Make sure you check out our website at www.fmpessentials.com for our blog and other content. If you enjoyed this show, please subscribe. Give us a like. It helps way more than you could imagine. Thank you for watching. Follow us across all social media platforms at FMP Essentials HQ. Please don't forget to share this with your practitioner friends, and we'll see you in the next episode.